Now, on to the show. So today in our...
It's the greatest show on earth, Matt.
Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is as confused by the latest study as I am by why people still ask me for a fax number. Who still uses fax machines in this day and age?
The FDA.
What do they use them for?
When we were at Novartis, they would send all their communications to us by fax.
Why?
Using Courier font, of all things. Literally, Courier font, typed on an actual typewriter.
Why?
I don't know.
I saw somebody who had an email signature and it said phone, and listed the phone number, and it said fax, and it said something like, why do you care? Or, something like that, which I thought was great. But really, the FDA still uses...
Yeah, it was fascinating. It's fascinating.
There's still the occasional times I have to fax something.
On the rare occasion that I see somebody using the fax machine, I walk up to them and say, what's that thing? What do you fax?
Yeah.
What?
So for my health reimbursement claims, you can either use snail mail or fax.
You cannot scan an email.
Nope.
Something wrong there.
Yeah.
Wow.
All right. Well, I am Matt Fox, professor of epidemiology and global health, and I am here with Chris Gill from the Department of Global Health.
Hey, Matt.
And we are fortunate once again to have in the studio, as Dante is away, we are fortunate to have Jen Ryder here with us.
Hi, guys.
From the Department of Epidemiology here at the BU School of Public Health. We are here in the Boston University Godley studio. So guys, I did something new, which is that I actually went to the Population Health Exchange website. Have you guys gone to it?
Yes.
Some really cool stuff on there. So this is Boston University School of Public Health Resource Hub for Lifelong Learning. And they've got a whole section with short videos and advice and tips, which is called Practically Speaking, which I found really interesting. A lot of interesting stuff you could find on there. Things like how to use social media for public health, how to do better and more effective science communications. So I would check it out. That's at www.pophealthex.org. And a reminder to all our listeners, if you go ahead and give us a rating on Apple Podcasts or iTunes or Stitcher or where else do you get your podcast? Vimeo.
There are so many.
That's a thing.
I was Googling myself the other day, as I'm wont to do, and
how often do you Google yourself? Is that like a
not every day,
but nice.
Often.
How often do you find anything new?
This time I found a lot new because I Googled Free Associations podcast.
Yeah.
And there are like 6 or 7 platforms that host all our, and including one in Danish.
Way to go, Nick. In Danish?
Or Dutch. Maybe it was Dutch.
Nick,
truthfully,
is this true?
I couldn't tell if it was Danish or Dutch.
Nick apparently speaks fluent Danish and translates the podcast for us. So that's pretty
impressed.
awesome.
I was impressed at
all
how,
right.
Yeah. And so when we say what is our readership, our listenership statistics, is that based on Google, right? But what about all these parallel? So where do these numbers come from?
Okay, there's a program that Nick enters there's this code that Nick enters into the link. I'm making this up, and it then goes to a service before it goes to the downloader, and it identifies that you have downloaded the podcast.
So how many subscribers are you up to now?
40 million.
Wow.
That is not as many as I thought.
Apparently, Nick is saying it's more like 400. I don't know.
Closer to 400.
I don't know. So we don't know. So what we know is we get roughly, after about a month, we get about 600 to 700 downloads per episode. That's roughly where we are.
That's great.
We should get more than that.
We should. Everyone who's listening, please tell all your friends and neighbors. I find kids really enjoy this podcast.
Yeah,
definitely,
trips to Maine.
Trips to Maine are definitely...
Trips to Cleveland, too.
Depending on where you're starting from, you might have a lot of episodes you can listen to. I have no idea at this point even where in the script I'm supposed to be. So while I do that, Jen, can you tell us how often you Google yourself and what you're looking for?
Well, we can maybe talk about this later, but when I Google myself, I often find very interesting things.
Oh, boy. So, yeah, there's some history there. There's a reason for that, given what it is that Jen studies.
What do you study?
So, in general, I just study prostate cancer. I mean, that's not that unusual, right? But I do have one paper on ejaculation frequency and prostate cancer risk that generated some very interesting headlines, I would say. And even more interesting,
gonna
stock
wanna-
Can you
art.
cut
People are gonna wanna
Chris'
know.
microphone before he says anything here? Let's just walk away from that one.
Sorry, Chris, what was that?
Was there a direct or an inverse relationship?
Yeah, so I mean, there was a fairly strong inverse dose-response relationship with number of ejaculations per month and risk of prostate cancer. And this was a large study, 30,000 guys, more than 4,000, almost 4,000 prostate cancer cases followed for 18 years. So yes, the major finding was that ejaculation frequency in midlife positively affects long-term prostate cancer risk.
That could be one of our
good
studies
news.
at some point. Now, on to the show. Today, in our first segment, which is our Journal Club segment, we are going to talk about a study on the effects of low-dose aspirin and whether or not it is actually the effects are related to body weight or BMI. Then in the second part of the podcast, which is our deep dive, we're going to go back to something that we talked about in an earlier episode, which is the placebo effect and some new thoughts that I and others have on this. And then in our third segment, which is our amazing and amusing, we will get into some of the things that we find awe-inspiring, or I will tell you about yet another one of my many fears, if you're lucky. Oh, by the way, so I wanted to just say we have been getting more and more feedback and suggestions from listeners, and I want to really thank them for writing in and taking the time. Keep it coming. We will take all your ideas. We can't necessarily go with all of them, but we really appreciate it, and we will send a response if we can. So now on to the first segment. So in segment 1, we are going to talk about an article that looks at whether we are using the right dose of aspirin in order to prevent strokes and other negative consequences. The study was published in The Lancet with first author Peter Rothwell of the Center for Prevention of Stroke and Dementia at the University of Oxford in the UK. The study was titled The Effects of Aspirin on Risk of Vascular Events and Cancer, According to Body Weight and Dose Analysis of Individual Patient Data from Randomized Trials. That is quite a mouthful of a title. So, as always, Chris will drop some things on the floor while I read the headlines. They are as follows. So, the Mirror UK says, scientists reveal the correct doses for daily aspirin takers, and the results may surprise you. Forbes says, an aspirin a day? ? Not so fast. MedPage Today says, down with one-size-fits-all approach to aspirin, researchers argue. The New York Times says, an aspirin a day for heart health? It may depend on your weight. And Pharmacy News says, do most patients need higher dose aspirin to prevent vascular events? So you can see those headlines are pretty all over the place. So let's get into the study. So Jen, can you break this study down for us? Tell us what they did and why they did it, or anything else you want to tell us?
Sure.
This was a complicated one.
This is a monster of a paper. So you all have talked about the phenomenon of salami slicing on prior episodes. So cutting up a paper into its smallest publishable parts. You cannot accuse these authors of that.
This is salami making.
But what I like about it is it's almost what seems like a naive question. Should we be giving bigger pills or bigger doses to bigger people? And you might think, surely that's been addressed for a drug as common as aspirin. But it turns out that it really hasn't been.
Yeah, kind of amazing. That shocked me.
It was surprising to me that this is not an answered question.
And don't you kind of wish you had that idea? I mean, it's so simple and elegant. Yeah.
Because then I'd be published in the New England Journal of Medicine.
Well, isn't it the Lancet?
Well,
but,
whatever.
I mean,
whatever.
Close.
Equally as good if you're listening, Lancet, and want to publish anything of mine. Anyway, sorry.
Sure. To you, Richard.
So a little bit of background. So weight or body size based dosing is actually used for some other types of drugs. So
most drugs, in fact.
Really?
Yeah.
You would say most drugs?
Most drugs, yeah.
Okay.
Like if you go to pediatrics, I mean, the pediatricians are constantly pulling out their little calculators and dosing Tylenol by the mil.
But for
or
adults?
the half mil. No, less so for adults.
Yeah, so they say
they do for peds, but not for adults.
Yeah, so for thrombolytic medications to dissolve blood clots, for instance, that tends to be weight-based. For intravenous antiplatelet drugs, there is weight-based dosing, but not for oral antiplatelets like aspirin. And that's what these authors have called, it's a one-size-fits-all approach, both out in clinical practice and in the design of trials. Yeah. So aspirin really works by inhibiting platelet aggregation and does that through this COX-1 mechanism. Previous studies have found that aspirin reduces vascular events pretty modestly. Mm-hmm. So it hasn't been, there's some benefit, but it hasn't been so impressive. We know that body fatness is associated with lower COX-1 inhibition with low doses of aspirin, likely because obese people tend to have more platelet aggregation and activation, but no one has really looked at whether the alternative mechanism, that meaning your lean body mass, could affect the effectiveness of aspirin on lots of chronic disease outcomes. So that's what these authors were really trying to do. So they had this hypothesis that higher doses of aspirin might be more effective in heavier people, but harmful in those with a low body weight. So what they did was they basically used the Anti-Thrombotic Trialist Collaborative and other reviews to identify two types of trials. First of all, primary prevention trials of vascular events that used either daily or alternative day aspirin versus no aspirin.
Primary meaning we're trying to prevent the first occurrence of strokes.
Exactly. Or any vascular event. Exactly. But first occurrence, that's right. And then they also looked at secondary prevention trials. So those would be trials in patients who've already had an event and are higher risk, to look for trials of aspirin versus control of stroke specifically. And those trials had to include at least 1,000 patients. So from those trials, they obtained a ton of individual patient-level data. So they had data on age and sex and height and weight and all kinds of vascular risk factors like smoking and diabetes, all major vascular events, major bleeds, cancers, and deaths that occurred during follow-up. And they also attempted to collect data on sudden deaths that occurred. And then one of their outcomes was the 20-year risk of colorectal cancer, because there's quite strong evidence. I would say among all cancers, the evidence for aspirin being protective for cancer risk is strongest for colorectal. So they looked at that specifically, and colorectal cancer in that situation was assessed in post-trial follow-up. And I'll say that in those, they did some stratification by baseline variables. They had very little missing data. Things were like 99% complete. They used Cox models to estimate hazard ratios. And in general, they censored people at death or the end of trial follow-up. But they also did these secondary analyses that we can maybe talk about more, where they censored people at the time of discontinuation of aspirin use. And they do that to, what they say, avoid confounding by withdrawal of treatment. So then they look at a ton of interactions. So that's what this paper is about, all about interaction. So they're looking at interaction terms between weight and aspirin treatment, both using dichotomous and continuous weight. And they also looked at interactions with other measures of body size, so things like height, and then other measures that required sort of a formula and algorithm to compute, like lean body mass or body fat mass or body surface area. But the main analyses ended up looking just at body weight. And then they did even further stratification within those interactions, where they were looking at age of less than 70 years or greater than equal to 70 years, sex, smoking, BMI, the formulation of aspirin, whether it was enteric-coated or delayed release versus standard release, and also the period of follow-up. So within the first few years of follow-up after randomization or later on. So they identified 10 different primary prevention trials.
Wow.
9 of them had data on height and weight, and so were included in this study.
Nice.
7 of those were of low-dose aspirin, and 2 of those were of higher doses of aspirin. There were also 5 secondary prevention of stroke trials that were identified, but they ended up obtaining individual patient data from the 4 of the largest trials because one didn't include information on height and weight. There was 1 trial that was low dose versus placebo, 2 that were higher doses versus placebo, and then 1 that compared 2 different doses. Everything's reported in kilograms. I don't know about you. I don't think about think in kilograms, I think in pounds. So the median weight for people included in this study ranged from 60 kilograms to 82 kilograms. So that's from 154 to 181 pounds. So 60 kilograms is about 154 pounds.
2.2 kilograms to a pound, is that right?
That's right.
Yes. And the median weight in women was 68 kilograms, or about 150 pounds. And then in men was 81 kilograms. I think that's about right around 180. Okay, so are we ready to get into the results?
I am.
Yeah.
But there are a lot of them.
There's so many.
Give us the important ones.
Okay. So when we're looking at low-dose aspirin, they found, first of all, that there was evidence of effect modification by all the measures of body size that they looked at, but that body weight was the strongest modifier.
And just to be clear, when you say effect modification, the effect of low-dose aspirin differs depending on whether or not your BMI is, say, high or low.
But not BMI, actual body weight.
Body weight.
But that brings up a really important point, and that's that even when they controlled for BMI, the same phenomenon was true.
Within BMI. Different weights have different modifying effects on the effect of aspirin on vascular events.
So it really seems like these are separate mechanisms. There is the lean body mass mechanism, right, that's captured more by body size, and then there's another sort of body fatness mechanism. But what they're really looking at here is the effect of body size and lean body mass.
As measured by weight.
As measured by weight. But it turns out you see the same types of results even if you look at something like height, or if you use a formula to try and estimate lean body mass in particular.
Okay.
So in the primary prevention trials, they found the greatest effect on cardiovascular events in participants who were in one of the lighter categories by body weight, so the 50 to 69 kilogram category. So that they had the strongest protective effect of low-dose aspirin. So they found a hazard ratio of 0.75 with, pretty narrow confidence limits. That effect was even stronger when you looked at aspirin that was taken daily. So there, the hazard ratio went down even to 0.68. But what they found is that there was a loss of effect in those who weighed 70 kilograms or more, and that was even more pronounced when you looked at the enteric-coated or delayed-release aspirin.
When you say the loss of effect, meaning there is no effect.
There is no effect.
No beneficial effect of low-dose aspirin at the higher weights.
Exactly. Starting at 70 kilograms. One interesting thing, though, that they found for the low-dose aspirin that doesn't quite fit in with that trend is that among those who weighed less than 50 kilograms, there was no benefit on cardiovascular events, and there was actually an increased risk of all-cause of death. So the hazard ratio for any cause of death was 1.52, with confidence intervals ranging from 1.04 to 2.21.
That's for patients with weights
below 50 kilograms. Yeah. So that's 110 pounds. So those are very light.
So presumably
people.
Something else is going on with that population, that they are just sicker in general somehow.
And to even further support that, when they excluded participants who had a BMI of less than 18.5, which would indicate that you were underweight, they no longer saw that sort of adverse effect of low-dose aspirin. So one of the interesting things about this paper is it clarifies potentially some discrepancies across different patient populations. So, for instance, they found that low-dose aspirin prevented stroke in women but not in men, but then there was actually no difference after they accounted for weight. That was completely a weight-driven finding. Yeah. They found very interesting interactions with low-dose aspirin and smoking. So the protective effect on cardiovascular endpoints diminished in smokers. They weren't deriving as much of the benefit from low-dose aspirin, and there was actual harm in smokers who weighed 70 kilograms or more with low-dose aspirin. There was this increase in case fatality of first cardiovascular events in those who were 70 kilograms or more with low-dose aspirin that were driven primarily by myocardial infarction, and also an increase in fatal first cardiovascular events in those who were 70 and older. And aspirin, as we know, there is a risk of bleeding associated with taking aspirin. And that was apparent in this study, but even with low-dose aspirin, but was lost in participants who weighed 90 kilograms or more. So there was a risk of bleeding, but once you were 90 kilograms or more, there wasn't any risk with low-dose aspirin.
Again, totally makes sense.
Totally makes sense. Totally makes sense, but I don't know that we really knew that.
Right. I agree. We didn't know that.
Yeah.
But it totally makes sense.
Yeah. Okay.
Yeah.
Great.
Totally believe it.
It's
All this
plausible.
sort of hangs like, little people.
Like you would expect.
A small dose is going to work in a little person, but is not going to work in a big person. And the big person is going to have fewer side effects due to bleeding for the same reason that it didn't work. Because if it's going to work, it's going to increase your bleeding risk.
Yes.
So it's all the same thing, flip sides of the same thing.
Okay. So, and the secondary prevention of stroke trial results, more or less similar. I'll sort of skip over those.
But then we get to the high dose aspirin.
And now we'll get to the high
dose. Which is where I totally okay, I no longer understand this paper at all.
Okay, great.
So give us the high dose, because that was an interesting piece of this.
The protective effects of higher doses of aspirin on cardiovascular events increased with increasing weight. So for high-dose aspirin, the heavier you are, the more protective the aspirin was. So effect modification going in the opposite direction is what we saw for low-dose aspirin. That was true for vascular event incidence and for death, and both in the primary and secondary prevention trials. In the primary prevention trials, 325 milligrams of aspirin reduced cardiovascular events in those who weighed 70 kilograms or more with a hazard ratio of 0.83. And in those who weighed 90 kilograms or more, 500 milligrams of aspirin reduced these events with a hazard ratio of 0.55, as well as cardiovascular deaths. Hazard ratio of 0.52. So again, it seems like the benefit you derive is dependent on receiving the dose that's appropriate for your weight. Using all the data from sort of the low dose and the high dose aspirin, they created this optimal dosing schedule that was weight-based. So basically, they came up with recommendations for weight that would produce the largest reduction in cardiovascular endpoints. So the recommendations were 75 to 100 milligrams for those who weighed 50 to 69 kilograms, 300 to 325 milligrams for those who weighed 70 to 89 kilograms, and at least 500 milligrams for those who weighed at least 90 kilograms. There was this suggestion that the risk of sudden cardiac death in the primary prevention trials increased when this optimal dosing schedule was exceeded, but not when weight was below the threshold.
Yep.
So it seems like if you're going above this recommended dose for weight regimen, you have risk of death.
Yep.
Unlike the low-dose aspirin, where there was a threshold at which the major bleeding excess risk was no longer apparent, for high-dose aspirin, the excess risk of major bleeding increased with weight. So those are the main findings just for the cardiovascular endpoints.
All right,
Do you want to digest those before we talk about cancer?
I think we should take those on, because I think there's more than enough for us to get into. So, Chris, I mean, this is a complicated study. This was a lot of information, and it tells an interesting story, but it's also a little puzzling in places. So, what's your critique of this one?
Well, this one forced me to go back to my basic pharmacology. So looking at my old Goodman and Gilman's clinical pharmacology text from med school, which I remember reading 25 years ago and remarking that aspirin is a really complicated drug. That, the way, or at least the way it was understood to work was extremely tricky. And trying to sort of reconcile the results there with what we know here and what we've learned about aspirin subsequently. So to quickly summarize that, the anti-thrombotic effects of aspirin, that is to say the things that stop you from clotting, are due to inhibition of an enzyme called COX-1, cyclooxygenase 1. But as the name implies, there's also a cyclooxygenase 2, which is what the drugs like Vioxx were supposed to target, with the belief that the Vioxx-like drugs, by attacking the cyclooxygenase 2, would not lead to an increased risk of bleeding. And in fact, that turned out to be true, but rather too true for their liking, because it turns out that COX-2 inhibition leads to an increase in thrombotic events on an absolute scale. So that's why Vioxx was removed from the market, because it seemed to actually slightly increase your risk of heart attack.
Yep.
And so going back to look at aspirin's pharmacology, aspirin at low doses has a very potent effect on irreversibly inhibiting COX-1, which would make you more likely to bleed, which is what you're trying to achieve when you're trying to prevent heart attacks, is to make your blood thinner. But at higher concentrations of aspirin, you start to get inhibition of COX-2 as well, which could lead to a prothrombotic effect. And so the results here that seem so counterintuitive, that in small people, low-dose aspirin is effective, which seems to be a direct dose response, right? That as you get bigger, that small dose becomes less effective because you're just diluting it by that much more body mass. That totally makes sense to me.
Yep.
But the high dose aspirin, which doesn't really have an effect or seems to have a slightly harmful effect amongst the smaller people, but becomes neutral and eventually beneficial at the higher weight people, could be actually what we're seeing is this relative inhibition of COX-1 versus COX-2 as a function of the concentration of aspirin. So it could be that we're looking at sort of a U-shaped, a hill-shaped, a bell-shaped curve. It's not a linear curve, like more aspirin equals more blood thinning, but that more aspirin at some point reverts to becoming less blood thinning and less and more prothrombotic. So I'm totally waving my hands here. I don't know if that's what's going on, but at least the basic pharmacology said that this could be an explanation for what we're seeing here. It could all be that there's a dose-dependent effect on COX-1 versus COX-2 inhibition ratios, and at the higher doses, you're starting to get a slightly prothrombotic effect. But all of this does reinforce what Jennifer was saying, is that it probably means that we really should be paying very close attention to the doses of aspirin and not just saying 81 milligrams, which is the standard dose that you get at CVS for low-dose enteric-coated aspirin. That is probably a far too simplistic way of using this complicated medication.
Okay. All right. So I want to get into some stuff that we haven't really talked about, because fundamentally this paper is about effect modification. Or is it?
Yes, I think it is.
Or is it?
I knew you were going to ask that.
This is what I want to go. So when we talk about effect modification, we're essentially saying the effect, quote in quotes, of the particular intervention differs within levels of some third variable. In this case, does the effect of aspirin as a preventive measure for vascular events differ depending on the size of the person, the weight of the person? And we need to be clear that we're talking about, in this case, relative effect measure modification, because you can have, in theory, you can have relative effect measure modification and no additive effect measure modification, and you can have the opposite actually occur. So you want to be very specific in what we're talking about. We're talking about relative. But my question is this really effect measure modification, or is this potentially mediation, or is this potentially just dose? Dose defined as dose per kilogram.
I'm not entirely sure I understand the distinction you're drawing here.
That is why I'm going to turn this one over to Jen. So
Dodge that one.
The distinction being, with effect modification, we are saying the effect differs within levels of weight. With dose, I'm saying that actually what really matters here is the amount of dose. The effect is the same, but it's dose per kilogram that what we really need to define it. Mm-hmm. And we're not able to look at that because they didn't use the same dose per kilogram across different groups of people, and therefore you can't actually. Well, maybe you could actually. I suppose you probably could.
And that's what everyone did originally, right? They were just looking at the same dose across all individuals.
The same dose, as opposed to if you change the dose to dose. You dosed everyone at the same dose per kilogram,
right.
Got it.
Then you could look at something different. You'd probably still look at this.
Which in theory, they could have done in this analysis, is to look at an indexed concentration by weight.
Agreed.
To see if there's an effect there. Yeah. That's not just dose, but dose is an effect modifier, right?
Yep.
Okay.
Or is the effect somehow mediated through weight? That you have some effect of aspirin use on vascular events that is mediated through a person's body weight, and that somehow if you were to change that person's body weight, you would change the preventive effect. Different ways of thinking about the same thing, or are these fundamentally different, or what's your reaction to that question?
Well, I think they're all related, because in your third question, I think that's true. I mean, I think the idea would be if I weighed 150 pounds today and I lost 20 pounds and weighed 130 pounds tomorrow, that the dose that would be required to be effective would also change, right?
Yeah.
Mm-hmm. So I think that is true. I also think that it is a question of a dose question so they could have analyzed the data in a different way where it was dose per kilogram.
Can I interrupt for a second?
Yeah.
I take it back. I take back what I said.
Okay.
Sorry. With mediation, we're saying that aspirin would affect BMI. Would affect weight, which would affect vascular events, which is not the case.
Yes.
Okay. So sorry, I got myself confused for some reason. Throw that one out. That one I'm pretty confident is not happening.
That's not going on.
Okay, so we've got effect modification, effect mediation, and effect arbitration.
Dose. just a dose
just
response.
Walk it back there. Yeah.
Just a dose response was the third one. But we're going to throw that one out. And so maybe they are. Maybe I'm getting at the same things.
But I think the reason they didn't do that, and I'm guessing here, that they didn't look at dose per kilogram, because they wanted to also look specifically at the effects of BMI. And then the interpretation becomes much more complicated. So I think it's easier to interpret the results of a model when you're looking at the interaction between aspirin and body weight when you control for BMI than if you had a dose per kilogram measure and then you controlled for BMI. So controlling for BMI is saying regardless of body fatness, right, or obesity or whatever, you still see this body size effect.
Good point. Good point. Okay.
Yeah, because body mass index is really a measure of the composition of your body. You can be a 50 kilogram person with a very high BMI because you're 2 foot tall and weigh 200 pounds.
Yep.
Right. Exactly.
As opposed to an 8 foot person who is a skinny beanpole who weighs 200 pounds and looks like a stick.
Yeah, and I think
because they're really tall.
Because they're really tall.
And in the paper, I think they make a nice argument about why lean body mass would be important for the effectiveness of aspirin, because that mass correlates with the tissues where this would actually be occurring.
Right, presumably.
Yeah, presumably.
So I like this study a lot, but it is complicated. One of the things that just does bug me about this study, which I find from so many, is that you've heard me get on my soapbox about this before, is they don't really ever present the risks of these events. So the only place you can actually really find it, there's some limited amount of data in the paper that you could actually try to calculate it, but they don't tell you over what time is. There is an appendix which eventually gives you the Kaplan-Meier curves, which shows that the risk of these events is we're in the neighborhood of 3 to 4%. Actually, I suppose I would say 2 to 4%, depending on what we're looking at for risks of all cardiovascular events or ischemic strokes over a period of 10 years. So it helps to put that in context when you're thinking about these protective effects on the nature of 0.75. I think there was the hazard ratio. So the second thing I wondered when I think about effect measure modification is it possible that what we're looking at isn't really so much as really big differences in the effects as just differences in the baseline risk of the event? That if you are a person with a low weight, your risk for vascular events is different from your risk if you have a high weight or a high BMI. And so the absolute effects could be the same, but the relative effects would then differ because the baseline risk is different. That appears not to be what's going on here, because if you do actually look at the risks actually differ very little by low and high BMI, which kind of surprised me. Low and high weight. Mm-hmm. Is that surprising? The fact that the baseline risk of vascular events doesn't differ much by weight? At least in this dichotomy of weight?
I don't know if I'm surprised by that.
Okay.
I was. Because there are a bit different body types.
Okay.
So, you can have, again, 5 people who are equally lean but weigh a different amount just because they're different heights.
Yep.
So I think it's a difficult thing to study in terms of cardiovascular risk, but it is a much easier thing to study in terms of the volume of distribution of an aspirin being dissolved into all the fluids of a body.
All right. So last question before we move on, which is, so this is a really interesting take on something that we probably thought was a known question and turned out it wasn't. Is this enough to change behavior, change policy, change the way that we dose people with aspirin to prevent
Well, I certainly think it's enough to change the design of trials. And maybe that could be the first step. So I don't know if it would be enough to change clinical practice, but certainly it seems like trials should be dosed based on weight, or at least that should be a component of those of trials. Right? I mean, one of the most interesting findings here is that, some of these trials were conducted exclusively among men. Some were conducted among women. You might look at the overall results of those trials and say, oh, the results aren't generalizable to women. It turns out it's all about body size. The women are just smaller.
Yep.
So I think that should definitely be taken into account moving forward. I mean, the other thing is that, as the authors point out, I mean, most participants in this trial, so 80% of the men and 50% of the women, and I'm assuming this is probably even more true in the U.S. general population, weighed 70 kilograms or more. So should low-dose aspirin ever be recommended, considering if such a small percentage of the population would ever benefit?
If we were only going to make one standard dose as the recommendation, it seems like we would.
That is not the one to make. Yeah.
Underdosing a lot of people.
Yeah.
Mm-hmm. Yeah. Mm-hmm. Chris, any last thoughts?
No, I just, or aspirin is an ancient drug, and it's an orphan drug, and I don't know how much appetite there is amongst pharmaceutical companies to invest a lot of money in running clinical trials on aspirin dose finding.
Yeah.
So maybe this would come from like the American Heart Association or sponsored by NIH or something like this, but this is not going to come from the pharmaceutical companies.
Sure.
So it may be that for quite a long time that an individual patient meta-analysis based on, randomized controlled trials, this may be the best we've got.
I think you're right.
And I suspect that this will have an impact on practice.
Yeah.
And it probably should until we have better information. This is the best we've got.
Yep. Okay, I'm going to leave it there. Unfortunately, there is a lot of other interesting data on the cancer outcomes. We'll have to leave that for another time, but it's worth reading this paper and just looking at that as well. So let's move on to our second segment, which is I want to get back into something that we talked about on a previous segment and hopefully get a different perspective, which is the placebo effect. And Chris is looking around as if he has no understanding that this is the topic. So
no, I read this twice.
Jen, this is apparently going to be a conversation that you and I have. Chris will weigh in.
There are notes all over my papers. I take exception to this, and underlined bits.
Oh, well done. They were underlined though in the printout.
No.
Those are okay.
Look, can I just say that the placebo effect? It is a very interesting thing. It's a very potent effect. I got really irritated at my veterinarian some months ago when she came over to our house and noticed that the dog was limpy and gimpy and suggested that we give glucosamine to the dog. Glucosamine has a clear placebo effect in humans, has no biological effect at all. It is just a placebo, and yet dogs are not susceptible to human placebos because they do not know that you're giving them glucosamine. So this was like the stupidest thing I'd ever heard. Sorry if you're listening, veterinarian.
And did it work?
No, of course not. We didn't give the dog glucosamine.
So you're saying definitively that you know for sure dogs, animals in general, are not susceptible to the placebo effect?
Pepper, we are giving you a placebo. It will have no effect, but your mind-body experience will be altered by this, and your joints will feel better. Trust me. No, I mean, the Pepper responds to her name, and when you bang on the tin, that's her communication limit.
Jen, any pets?
Dinner time.
Yes, and it's so. I can't wait to get to amazing and amusing because I want to talk more about our pets.
You're going to be taking down a peg here, Chris.
All right, placebo effects. Let's go.
All right, so the question is this. So when we talked about them last time,
I'm feeling better already. Strange. My mind and my body are just.
This is a Chris Gill placebo. So we talked about this previously, and Chris, you presented some data that suggested that there was some real good evidence to suggest that the placebo effect was real. I mentioned this in a tweet. Something came up about placebos, and I mentioned this. And people were very critical of the literature that you pointed to, which compared placebos to no treatment, saying that in those studies, there is potential for serious confounding. In addition to which, the other argument, and this is the one I'm even more interested in, is the idea is much of the placebo effect really regression to the mean? And I say this, so I'm going to go back to an article that we did on depression. So we did a couple of different studies that we looked at on depression and antidepressants specifically. And in these trials, so these were trials that we actually had some concern with. in which they compared paroxetine to imipramine. Do you remember these? Remind me what paroxetine and imipramine are?
I don't remember the brand name for imipramine. Paroxetine is Paxil.
Paxil. I think. Okay.
Paxil.
Yeah. And they have this drug looking at differences in I think reported it was the HAM-D depression score, in which all three of these groups, those who got drug A, drug B, or placebo, all three of them go from high in the beginning down, drop dramatically. Supposedly the one group drops a little bit more than the others. And I made the statement when we first looked at this that what this tells me is actually there's this placebo effect, and we should be taking advantage of this. We should give people a placebo first and then see if they get better. And if they don't, then we would treat them with something else and see if it works. And re-looking at this now, I'm thinking, no, that's not what's going on. There is no placebo effect. This is just regression to the mean. That these are trials that are enrolling patients who are at an unusually high point in their depression because that's what made them eligible for the trial, and giving them the placebo does nothing. It's not a placebo effect. They're just going back to normal. So is the placebo effect real or is it not? Jen, what's your take?
So first, I just want to clarify something.
Okay.
This is only an issue when we use self-reported outcomes, right?
Probably.
Primarily.
Probably. Yeah. Although, I mean, if placebo effects are real in affecting things like pain, in affecting things like, depression, theoretically, that could have some small long-term mortality benefit.
But let's say we had a perfect depression biomarker. Would we see the same thing?
Maybe, I think.
Maybe not.
If you believe, hang on. If you believe in the placebo effect. I'm not saying I do anymore. I'm not saying I don't. I'm just saying I'm less convinced.
Yeah.
But hang on. So go back to Chris, answer the question.
What do I think about the placebo effect?
Do you think it would Jen's question, do you think it would lead to biologic changes if we had some biologic marker of depression?
I think that's a trickier one. I think it's a trickier one because the self-reports, the experience of the symptoms could well have a reciprocal effect on the biology of the process behind it. I don't know. I think with mental health, the mental health biomarker. I'm just trying to wrap my head around what that would mean and what you would be measuring. I think there are other disease states where it would be probably a little bit easier. And I'm thinking this study of albuterol versus sham albuterol for people with asthma. And then they were wheezing and they measured their forced flow rates and showed that there was obstruction of their airways. They then gave them albuterol or they gave them sham albuterol, and they measured their symptoms afterwards, and both groups improved to almost the same degree in terms of how they felt. But when they also looked at the FEV1s, which is the measure of airflow, only the albuterol actually improved the airflow.
Yeah, I think that's a great example.
There you go. So that was the placebo effect. They felt better, they reported feeling better, but the biology didn't change. I
see what you're saying.
So I think the placebo effect is dependent on the subjectivity of your own reporting.
Absolutely.
So I can say I'm in a lot of pain right now. I take my placebo. I might say I'm in a little less pain, but objectively, that pain is actually, if it could be measured accurately, would be the exact same level.
Looking at the concentration of prostaglandins in your knee or something like that.
Exactly.
Would be the same.
Yes.
And so one of the responses that I got on Twitter were these articles that I sent around to you all, which there are these groups that are claiming to take advantage of the placebo effect. They're doing these trials where they claim to actually tell people, I am giving you a placebo. This will not do anything to you. This is
it's a little
inert
bottle
substance.
Labeled placebo.
It's labeled placebo. And yet they claim to find effects in terms of what we would probably consider subjective outcomes. Do you buy these trials?
I think we're referring to this paper in PLOS One, right? That was the genesis for this lengthy narrative by Dr.
I think
Gorski.
the outcome was these were all patients affected by irritable bowel syndrome, from what I remember. Yes.
Exactly.
Right. And they were told that they were going to get a placebo, and it was going to be labeled a placebo, and the placebo did nothing, but it might activate their mind-body axis in some way to make them feel better.
But there was a very controversial part of that, and that's that the investigators told the participants all about how effective placebos can be and how helpful they can be, and that it was this real scientific thing that we understood, and they just had to harness it.
But what they did is they sold the placebo.
Yeah. Wait, sold as in
like this placebo, as opposed to that placebo, is going to be great for you.
we have scientifically determined the right placebo for you.
It's going to be the best placebo. The best placebo ever. It will be stupendous.
Yeah, right. They told people what it is that this placebo was going to do to them.
Take this placebo to Helsinki. It will be the best placebo.
Helsinki? You lost me there.
Geopolitics,
that was a reference to the Helsinki summit, but
talking about the national economy and our. Anyway, getting back to health.
Okay, so are you saying that you have more skepticism about the placebo effect now, less skepticism? Where are you?
I think Gorski makes a really good point, as Jennifer said. They say Gorski is the highly critical professor at Harvard who wrote a long blog attacking this paper in
Placebos Without Deception, a randomized controlled trial in irritable bowel syndrome.
And who was the authors on that? We should probably mention.
I don't have that one.
It's in there somewhere. Anyway. He basically said that, placebo without deception, that claim was immediately refuted, as Jennifer is saying, because they then went and actively sold the placebo, saying this is a placebo, it will do nothing. This is just sugar pills, it'll do nothing. It's totally inert. This will do nothing. But this is going to make you feel better, way better.
Do you guys remember the Steve Martin? Placebo. I am taking this great new drug. It's called placebo.
Right.
So good. You should look it up.
It's up there with his tuna fish sandwich thing.
I don't know. The Jerk is one of the greatest movies ever made.
I did enjoy that film.
Although I say that, I haven't seen it in many years. And many of the movies I've been watching recently, of old movies that I've watched, don't hold up.
They disappoint.
So, and they turn out to be horribly sexist and offensive. So maybe I'm wrong. All right. So any last thoughts on placebos?
Well, I think placebos are the friend of the clinician and the enemy of the clinical trialist.
Let's say if placebos worked, there was a placebo effect, would it be ethical to use them?
Yes, because we do it all the time.
Meaning what?
I mean, clinical medicine, where a lot of the stuff we do is just placebos. We wrap people, we put those little, stretchy bands things in pink and green.
Wait, that doesn't do anything?
No, it's just...
Totally does.
It's just, it only works if it's pink.
Have you all seen the study of the effect of mommy kisses?
I was just going to ask about that.
Band-Aids. Well,
mommy kisses are effective.
Yeah, they do. I mean, a lot of things we do in medicine are placebos. We don't even necessarily know them. We may have perfect faith in them. One of the big concerns I've heard voiced in medical circles is this fear that evidence-based medicine is systematically chipping it away at all our placebos and therefore rendering us weak clinicians more impotent. As another thing is shown not to really work, you're like, okay,
get another one of your...
Come on, patient comes in very miserable and say, well, truth is we've got nothing. Everything we've got doesn't work. Sorry. I mean, you can't say that. What you want to say is like, oh, your viral upper respiratory infection that's making your sinuses hurt so much. Here is some azithromycin and a Z-Pack. You'll feel better in a week, which is true. You will.
But not because of the azithromycin.
Exactly. Yeah.
All right, I'm just gonna end this then by saying I have more skepticism than I had before. That I do think there is a big component of the placebo, or what we are calling the placebo effect, or have been calling the placebo effect, that is really just regression to the mean, and it does make me rethink whether or not we could really harness it if it's not really a real thing. So I'll just leave it at that. And we can move on to our third segment, which is our Amazing and Amusing, where we want to highlight some of the things that make us enjoy our jobs even more than we already do. And we do really enjoy our jobs. This is a look at the weird, wacky things that happen in our field. Although I guess I don't have to say that since Don isn't here. And it could just be what it really is, the amazing and amusing things in our field.
Are you going to talk about the digestive system in any way, Jennifer?
I hadn't planned to, no.
Okay, then I will.
Okay, then Chris is going to go first.
He is very eager.
As always, take it away, Chris.
No, hold on. All right,
Tell us about the digestive system.
So this is because Don is not here, and I figured someone needs to fill the void.
So I worry about the term "fill the void."
This is a story about a common problem we see in intensive care units, which is C. difficile colitis,
Something
which we talked about
on the pod.
So C. difficile is a bacteria it's an anaerobic bacteria. It forms spores, and the spores are like disseminated into the environment out of people's backsides, and they get everywhere, and they are incredibly hardy. They cannot be destroyed by UV radiation. They're resistant to alcohol, so like alcohol hand washes do not work. Washing them off with soap and water is really pretty ineffective. Then the only thing you can do to kill them is using concentrated bleach. And so they spread like wildfire in intensive care units and cause very, very severe colitis,
very severe,
which is difficult to treat and is occasionally fatal. So it is a real problem. Now, as C. difficile became more common, this I think urban legend emerged in ICU nurses that they stated that they have the ability to smell C. difficile and tell that this patient's stool smells like C. difficile versus that patient's stool who does not have C. difficile.
This is something you've actually experienced?
I've heard
as a doctor?
So many nurses make this claim, actually.
That you can
tell. I can tell. That patient smells like C. diff. And you're like, oh, right, I can't tell, but I wouldn't doubt it because this patient's got fever and a high white count and wicked diarrhea after taking a course of antibiotics for their ventilated pneumonia. So I would have guessed it was C. diff too, but in terms of being able to smell it, I can't tell. So
this makes me glad I'm not a clinician.
Right. I mean, it's
Did somebody do a study to find out?
Many studies, as it turns out.
To smell?
There were a whole flurry of projects in the early 2000s where they basically assessed nurses' ability to like identify patients with C. diff based on the smell of their stools.
Gross.
Yes. But in all of those trials, the nurses were very accurate at identifying C. difficile colitis.
They were not?
They were highly accurate. But the problem was that in all cases they were not blinded to the clinical information about that patient. So there was huge bias. Yeah. Like, here's a patient who's got wicked diarrhea and a fever and a high white count after taking antibiotics for their ventilator pneumonia.
Smell this.
And I think they've got C. diff, right? I mean, so the experiments were really questionable. So finally, they got around to doing a truly blinded experiment where they assembled stool samples from 9 patients with diarrhea not due to C. diff and 1 patient with C. diff, and they had the nurses basically sniff them blinded to all clinical information about what was the cause of their diarrhea.
They consented them for this, right?
Yes, and
the
nurses,
you will be sniffing
their success rates were no better than a coin flip. So when blinded, the nurses could not do this. So it seems to destroy this urban myth, and we're like, okay, well that makes sense because really, what could you be smelling? But the thing is that C. difficile apparently does release a cloud of characteristic volatile organic compounds that in theory could be detected if you had like a mass spectrometer so they could say, oh yes, that is C. diff right there. See those spikes? But are nurses able to have their nose calibrated to be like a mass spectrometer? Apparently not, according to this more recent study.
Not a very big sample, but
what about other animals that do have better senses of smell?
Dogs!
So they got dogs. So they brought in a beagle dog into the ICU and they trained the beagle dog with rewards and treats on how to identify C. diff. And this beagle dog was awesome at identifying C. diff. Absolutely nailed it. 100% sensitive.
I'm not at all surprised.
Always got it right.
This is the same beagle that sniffs me in the airport and always finds the ham sandwich that I forgot in my bag. Same guy?
After he retired from the TSA. Went into research.
No way. So he was really good.
Yeah, so the dogs really can do it. So, is there a subset of nurses who have highly refined olfactory senses who might be able to actually do this? I don't know. It's
Can we assume the dogs are blinded?
The dogs were blinded to the clinical status of the patients.
We're sure.
How? What?
Beagle dogs are
I would say if you're worried that they're telling the dog this one has.
If it was a German Shepherd,
giving subtle cues.
Well, exactly. Did the patients look ill in other ways that the dog picked up on?
Well, yeah. That's a good question.
Were they smelling the patient or they were smelling the stool?
Let me see.
really matters.
The Beagle Dogs. Here we go.
The Beagle Dogs.
I got to pull up the abstract here. It is.
Yeah, you got to do some serious.
Oh, they don't
Beagle
have an
blinding.
abstract. This is.
They're very bright.
They are very
okay,
bright.
here we go. The dog was guided along the wards by the trainer who was blinded to the participants' infection status. Each detection round concerned 10 patients, 1 case, and 9 controls. The dog was trained to sit or lie down whenever it smelled C. diff. And the sensitivity and the specificity for detection of C. diff was really good. Sensitivity 83%, sorry, not 90. And specificity was 98%.
Okay, I just have to point out, this is the best figure one I've ever seen in a paper. It is a picture, a photograph of the beagle in his cute little vest.
I love it.
At the hospital.
So cute.
Sitting on the ground, yeah. Yeah,
Oh.
Snoopy dogs.
All
Now,
right.
maybe if you do this with German Shepherds, it would be a different result.
Maybe. That's important. All right. Well,
That leads right in.
All right. Take it away, Jen.
So, so now I know that you have a dog, Chris. Matt, do you have a dog?
I do. Jojo.
Jojo. Okay. So I have Wednesday in trouble at home.
Wednesday named after.
So we adopted them. She was Wednesday. They were Wednesday and Pugsley from the Addams
From the
family.
Addams family. Well, all
But
right.
Pugsley didn't really look like a Pugsley to us, so he became Trouble, which he does look like.
Whereas Wednesday looked like a Wednesday.
Definitely.
Is Trouble a pug?
Neither of them. They are mutts, terrier mixes. They tell us we don't really know.
Okay.
But they are lovely dogs, but not particularly bright like this beagle. I hope they're not listening.
Beagle dogs are known to be rather
Do your
dumb.
dogs listen to this podcast?
They do. They do. Yeah, they're forced to. But but I found this paper. I have to credit Eric Topol's tweet for identifying this one. But this paper was actually looking at dogs' empathy and their pro-social helping behavior. And so, I've often wondered, my dogs are, pretty nice to me, but would they actually try to save me in some situation of distress?
Cool.
Would they?
I'm much more optimistic after reading these papers. So they didn't seem to look at measures of intelligence in the dogs, but they looked at 34 different dogs. About half of them were officially therapy dogs, and the others were just regular old domestic pets. And they had a number of tests that they performed with them, with their owners. So they randomized the dogs to either a control condition or a distress condition. In the control condition, the owner was seated in this little room. It was made out of plexiglass, it seems, so the dog and the owner could see each other, but the only way the dog could get to the owner was by opening a door that was attached by magnets. In the control condition, the owner said help in a very non-emotional way.
Help.
And then, every so many seconds, and then in between that sang Twinkle, Twinkle, Little Star.
Yeah. Okay. Makes sense.
And then in the distress condition, the owner said help in a more...
Help.
Thank you. And then in between the help calls, cried.
Now, did we need this study? Because can we just watch Lassie? We know what
That's, yeah. If you're into the N of one, that would be...
Lassie's a documentary, right?
Yeah, absolutely.
Yeah.
Absolutely.
No?
So the really interesting thing is that regardless of the control condition or the distress condition, most dogs actually went and opened the door to get to their owner. So I think that's encouraging. But there was a suggestion that the distress condition was associated with faster opening of the door. And then they also did this experiment. It was called the impossible task, where the dog was trying to get food out of a jar that was actually screwed shut. And they were measuring sort of the distress of the dog and through its heartbeat and the amount of time that the dog spent gazing with either the owner or the stranger. And they found that dogs spent more time, of course, gazing at the owner than the stranger, but even more time actually trying to do these tasks. So I have more hope in my dog's ability to save me in an emergency. Given
Now, that doesn't actually get to the dog's actual ability. It's just their willingness.
Their willingness.
Yeah.
They would try.
They would try.
Yeah.
And
that's all we can really ask.
That's all we can ask.
Yeah.
Mm-hmm. Chris, your dogs, would they save you?
No,
Good.
my dog Pepper is not bright. It's not bright. She growls whoever comes to the door, and then if it's a stranger or if it's my wife, she will then lick their hand. Doesn't matter.
Ours is the he will, if you were to break into our house, he would definitely show you where the valuables are.
Yeah.
Yep.
Right away. Please follow me.
Yeah, absolutely. All right. Well, that's I suppose that gives me hope, though. A little bit of hope for JoJo. All right. So mine's a real short one, and it hits on a theme that I have hit once before, which is, what do you do when you feel like multiple people have contributed equally to a publication, and you've got to decide who's the first author, or let's say in this case where there are only two authors, who's the first and who's the last? Do you all have opinions on shared first authorship?
I've never done that.
I don't like it. I don't think I believe in it. Mainly, I don't believe in it because it's one of those things where one person is listed first and one is listed second, and then there's a note that says these are both co-first authors, but whoever sees that, and so it just strikes me as silly. Anyway,
I am a very frequent co-first and co-last author,
and it works for you.
Well, I mean, of course, would I rather be the sole first author? Well, sure. But
if you're oh, sorry, go ahead.
But I think there are a number of situations working in larger teams where there's only one first and one last spot. And sometimes it's just not fair to give that to one person. So especially with the last position, I think that role can be really leading up, overseeing the paper, or, if you're working on a large ongoing study, it might be the person who has maybe wasn't in the senior role on that particular paper, but in the larger project has had some major role.
And do you believe that they are truly co-equal first authors, or is the one who's listed first
equal in the eyes of PubMed,
externally as the real first author?
Well, it's interesting. So one thing that I was told, and this is something that I do, and now I'm outing myself and I may get in trouble, but on my CV,
we can edit these things out.
For publications where I'm co-first but might be listed second, I actually list that first on my CV.
Wow, what a good idea. Okay. All right. I like that. I don't know if it's...
And you include, and now, people would say, well, what if they tried to look that up and they'd look it up by a different... But you include the link to the paper, so it can still be
I like it.
found.
I like it. Okay. Well, I'm for mine, I have a solution that was used for this particular problem. These were two authors. This came from the Twitterverse. That
arm wrestling?
Tripped me off to this. No arm wrestling on this one. So this was A.M. Scheel and P.M. Isiger. I know A.M. Scheel is Ann Scheel. I don't know. I think it's Peter Isiger, although I may be wrong. So this is what it says in their acknowledgments section, or in their disclosure section. It says, A.M. Scheel and P.M. Isiger contributed equally to the manuscript, and the order of their authorship was determined by executing the following commands in R. They then list 3 commands that is a random number generator that then spits out a name of the first author and prints the winner is X, and that is how they determined who got to be the first author, which I thought was, clever. It's a random number generator, but it also, you get to put a little bit of R code in your acknowledgement section. I think that was
yeah, that's very nerdy in a great way.
Very nerdy.
Yeah.
Yeah,
I like it.
Absolutely. So that is the end of our program. If you got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at PopHealthyX, or you can tweet me at ProfMattFox, or Chris at ID.Gill, or Jen at Jennifer R. Ryder. Don't forget the extra R. Or you can find us on Population Health Exchange's website, which is www.pophealthex.org. We want to thank Leslie Talalian, Director of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode.